If you're here, you've probably heard about the infamous CASS report. We have people on one side who absolutely hate it and people on the other side who are cheering it on. But what's in it? I'll be doing a video series of what is in the CASS report. Some of the topics we will be covering is what is in the CASS report, the current gender climate, social transition, ecological intervention, puberty blockers, hormone therapy. But some of those will be in other videos. For this video specifically, it'll be what is the CASS report, its recommendations, and the current practices that the NHS carry out. The CASS report was commissioned by NHS England to make recommendations on the NHS services regarding gender identity, gender incongruence and dysphoria. In particular though, it focuses on children and young people. So as I stated before, this is part 1 of my CASS report series. If you're interested in the other topics, you can give me a follow so that you can stay up to date. The document is nearly 400 pages long, including references. So if there are any mistakes, it is not intentional. If I missed anything, let me know. A disclaimer before we start, this video will go through contents of the report for educational purposes. This doesn't represent the opinions or the views of the channel. I actually try and stay really neutral because I feel like there are a lot of people who give you their opinions and there's not a lot of people who will just kind of give you the data to make up your own opinion, so that's what I'm trying to do. This series is by no means expansive. There are some areas I'm going to be skipping. An example of this would be the methodology section, the history section, differing characteristics of biological sex, and potentially a few bits and pieces here and there. If you would like access to the full report, it will be down below. A lot of the information will be condensed down so that it's a more enjoyable watch. So without further ado, what is the CASS report? I should also say that all information that's in this video was found in the CASS report. There is no supplemented information or information that I found from elsewhere. This is an image of the review that they commissioned in the report itself. So one of the big reasons that I stated in the report is the failure of information that's already available for people who are experiencing this gender incongruence. So I'm going to briefly go over what they found and what they discuss in the report. So most of the guidelines that are already in place across the world have not followed international standards for guideline development. The research team for the CASS report only recommended 2 guides for practice, the Finnish guidelines of 2020 and the Swedish guidelines of 2022. The report claims that there's a failure to gather even the most basic of information, and the information that has been gathered has not been gathered in a consistent or comprehensive manner. Data is often not shared or not available. It claims that the University of York's work shows that there's a lack of high quality evidence in this subject matter, with attempts to improve the evidence base being shut down, especially by a lack of cooperation from the adult gender services. In conclusion, better evidence is crucial if the NHS wants to provide reliable information and advice to support kids, young people, their parents and carers in making potentially life-changing decisions. The CASS report also looked at the evidence themselves, and they found that the most common study in these areas was a pre-post study. I'll put the definition on the screen. The report claims that it's not possible to make strong conclusions based on these studies because there's no control groups. What that means is that they can't compare them with the outcomes of patients who did not have the treatment or who had a different treatment, and thus changes over time just couldn't be ruled out. And another type that they found was treatment trials. They go into the problems of these trials. So apparently treatment trials can have a bias. If a large part of the participants drop out, then the people who have remained may be the people who responded really well to the treatment, and vice versa for those who dropped out. This would report positive outcomes for the treatment trial itself and fail to show any of the side effects that caused people to drop out, potentially. It also stressed that sample size was important and other potential problems being unconscious bias in questionnaires, particularly like question wording, looking for good outcomes, the wrong type of analysis used in available data, not a long enough follow-up period for the full scope of treatment, which actually comes up a lot later on once we start getting into the nitty-gritty of the report, doesn't take into effect external factors which could improve patients' outcomes that's not actually the treatment itself, and a publication bias of only positive results being published. Now all that boring stuff out the way, we can start looking at the medical pathways that are already in place. This diagram shows the current medical pathway that was in place at the start of the report. So again, puberty blockers and estrogen/testosterone is usually called like endocrine treatment, and I'll be referring to the estrogen and testosterone treatment as kind of hormone therapy, just so that we're clear on the terminology. Let's briefly talk about the perspectives of perspectives, yes, of this service. So the report arranged focus groups of young people who expressed a desire for access to counselling and safe spaces to express their gender identity, but not as a replacement for a medical transition. They did recognise that there was a lack of reliable information regarding transition, and they wanted more reliable information so they could make informed decisions, including information about risks and side effects. So let's look at the problems identified in this structure that's in place. The report identified that there is a big issue, or the ability for children to be able to consent when relating to this form of care. It also expressed problems in judgments from clinicians as to whether a treatment is advisable for a patient or not, and issues in the information that the clinician is providing to a patient about the potential benefit and risks of a treatment, as well as obfuscating alternative treatments. So let's touch back on this ability to consent thing. So the report says that the way that the brain develops isn't even. So during puberty, that's when your limbic area of your brain develops, and that's the area that focuses on the present, particularly affecting risk-taking and sensation-seeking. During this time, it becomes super sensitive. So this drives up emotional volatility, pleasure, novelty-seeking, and also makes adolescents more sensitive to social rejection. During this time, there's also a vulnerability to addiction and a range of mental health problems. An individual in their 20s, however, is undergoing a different type of brain development. This is in the prefrontal cortex. So the prefrontal cortex is maturing, and this area of the brain focuses on the future. And in the future, it focuses more on executive functioning. Now, what does executive functioning mean? Well, it can kind of be broken down into complex decision-making, rational judgment, inhibition of impulsivity, planning, and prioritization. So what does this mean? Why am I telling you this? It's important because theoretically, an individual who is 15 will make a similar decision to someone who's in their 20s, or an adult comparatively. But the difference is they may still engage in kind of risky or dangerous behaviour, even though they know that it's risky or dangerous. Their emotions are more in tune with their decision making than an adult's would be. And this is particularly important in the context of you kind of have puberty blockers at 15ish and then go on to hormone treatment around 16ish. So I'll briefly tell you what the Bell versus Tavistock, I hope I'm saying that right, was about. It basically was this very issue got brought to the High Court, and a judicial review looked at it. It found that the process was lawful and that minors were competent enough to make decisions regarding this kind of form of care. The kind of things that they considered was whether they could understand the immediate psychological and physical consequences of undergoing this treatment. They also considered the lack of people who actually came off this pathway once they started puberty blockers, including hormone treatment, surgery, and its complications, including loss of fertility and sexual function. They thought about how this pathway may impact their future and their relationships, and that the evidence for all this is highly uncertain. Although they did say that it was lawful, they also concluded that it was doubtful that they would have such competence at 15/14, and it was highly unlikely that a 13-year-old and under would, which was what they were ruling on, so then that got overruled. Following an appeal, since the basis of the ruling was regarding their competence in making a decision regarding medical intervention. So that's a little background on that. So now we're going to move on to what's in place in existing care. So the majority of people currently who get referred, who look to the NHS for help, get referred to a highly specialised workforce. This workforce just focuses on gender care. A smaller number are sent to mental health services. This has made the waiting lists incredibly long. And it also de-skills the rest of the workforce who are now not seeing these patients. So one thing that we do see happening, some people will try and get into the kids' gender identity disorder services, and they wait so long on the waiting list that they age out and then get sent to the adult services, and then they get to the bottom of the list of the adult services. So they're not only just waiting for the kids' service, but they end up waiting so long they get too old and then have to wait in the adult service anyway. So now we're going to move on to the current guidelines internationally. I won't harp on it too long, but I'll show you a quick diagram. So I won't stay on this graph too long. This is just kind of showing you what the report outlined of all the individual reports and how they appraised them. So the report only recognised the Finnish and the Swedish guidelines as applicable as they underwent rigorous development. They were also the only ones that said that treatment should only be provided under kind of research circumstances due to the lack of robust evidence. They're also the only one that have been informed by an ethical review conducted as part of the guideline development. But these guidelines, like others, lack clear recommendations regarding certain aspects of practice and would benefit from more detailed guidance regarding implementation of recommendations. Only 5 of all of the guidelines actually used a systematic approach for finding and assessing evidence, but even then they didn't make it clear how they used the evidence that they found, especially since most of the evidence they found was considered insufficient, but it was used and cited later on in the guidelines anyway. The good news is that most were developed by a group of experts, but then they also consulted with professional stakeholders and service users with no clarity on how these affected the guidelines. And lastly, some of these guidelines used other guidelines for the basis of making some of their recommendations, meaning 7 guidelines influenced nearly all the other guidelines. I'm just going to quote this bit from the report because I think it highlights this really well. These 2 guidelines are so closely interlinked with WPATH, adopting Endocrine Society recommendations and acting as a co-sponsor and providing input into drafts of the Endocrine Society guideline. WPATH 8 cited many of the other national and regional guidelines to support some of its recommendations, despite these guidelines having been considerably influenced by WPATH 7. So the looped nature of how these guidelines are kind of intertwined with each other may explain some of the consensus that this kind of, I was going to say community, I'm not sure that's right, but kind of that gender services internationally have on areas of practice without the sufficient evidence to back it up. The report cast a lot of doubt on whether these guidelines are actually reliable, since most didn't follow international standards of guideline development. Let's quickly talk about WPATH and how it kind of influenced some of these guidelines, since it's had a considerable amount of influence in the development of a lot of them and for medical practice, but there may be a problem with that. Quoting again, the WPATH 8 narrative on gender-affirming medical treatment for adolescents does not reference its own systematic review, but instead states, despite the slowly growing body of evidence supporting the effectiveness of early medical intervention, the number of studies is still low, and there are few outcome studies that follow youth into adulthood. Therefore, a systematic review regarding outcomes of treatment in adolescents is not possible. A short narrative review is provided instead. So basically what that kind of says is that they just are looking at the short-term outcomes and then kind of applying that widely, at least that's what I got from it. But they did actually do a systematic review, and it is referenced in the chapter on W8 standards as one of the several references in support of their current approaches. And although using approach of clinical consensus is valid when evidence is very limited or inadequate, WPATH doesn't seem to do this. And instead it overstates the strength of the evidence that it already has, which we know is inadequate, and then that's what they use to make recommendations. So wrapping that up into a little bow, WPATH is influencing a lot of these international guidelines. The information that they're using is inadequate, and they're saying that they can get this information, so trust me, bro. Anyway, moving on, let's look at the current assessment and diagnosis process. I'm gonna take these off. So the good news here is that most agree that the assessment can be very important when assessing the needs of the individual in undergoing a psychological evaluation and constructing a care plan for them. I believe it's clinicians they're talking about specifically here, but they have kind of a varied opinion on what the assessment should be. So some believe that the assessment should be assessing whether medical intervention is appropriate, and others believe that it should attempt to make differing diagnoses and kind of rule out other things that could be causing their gender distress before considering that it's induced by dysphoria. But other opinions, and I believe these are from users of the service, they believe that the assessment should be to support individuals explore their options and understand these options better, or to get validation for their gender identity, make them feel comfortable, and to access medical pathways. So the University of York did actually ask, they call it GIDS, but it's Gender Identity Disorder Services, to participate in a survey to assess the assessment and record current practices in England, but they got ghosted. Therefore, they used a different report. I will show you a summary on the screen. If you want to pause here and skim through what the Multi-Professional Review Group's report was, which is MPRG for short, you can pause here. So the CASS report did try and get information on people who didn't access the endocrine services, as only a minority of them actually do get referred to these services, but they couldn't get any clear information on that. There was evidence that the Gender Identity Disorder Services did provide therapeutic treatments, and this was based on the number of times that they were seeing patients, but there's no formal structure on how that program is in place. Some of the staff think that the third wave CBT could be good and used to help gender distress, without altering their identity, but this wasn't developed into any sort of like research study. So when they tried to assess long-term outcomes for people who undergo this kind of care, it was very difficult. So one of the biggest issues when planning medical practices for this group is that there's very limited reliable evidence. I know I keep saying that, but it does keep coming up for long-term outcomes for this current treatment, especially in the gender identity disorder service. Well, maybe not especially, but that's what it says. This isn't helped by a seemingly lack of cooperation from this service, and potential research to actually find out what the long-term outcomes would be would take 10 to 15 years. And that again is for the follow-up data that we discussed earlier. So I'm going to kind of go over some of the conclusions in this report, and I kind of will just be quoting it because I can't condense it down anymore. So stay along and we're nearly there. And these conclusions will be encompassing other areas of the report that we will be going through in later videos. So if you're kind of confused, then don't worry, hang in there. Give me a follow and we'll go over them another time. Again, they include social transition, hormone treatment, puberty blockers, psychological evaluation, and the current kind of gender climate, changes in epidemiology, all that good stuff. This is kind of just giving an overview of what the CASS report is and what it looked at, but it's far too big to go over everything in one video. I am sorry. Forgive. So we're going to go over some of what the report recommended. So services must operate to the same standards as other services seeing children and young people with complex presentations and/or additional risk factors. NHS England should expand its capacity through a distributed service model based in paediatric services and with stronger link between secondary and specialist services. Children or young people referred to the NHS must receive a holistic assessment of their needs to inform an individualised care plan. This should include screening for neurodevelopmental conditions, including autism, and a mental health assessment. Standard evidence-based psychological and psychopharmacological treatment approaches should be used to support the management of associated distress from gender incongruence and concurring conditions, including support for parents, carers, siblings as appropriate. Services should establish separate pathways to pre-pubertal children and their families, ensuring that they're prioritised for early discussion about how parents can best support their child in a balanced and non-judgmental way. When families and carers are making decisions about social transition of prepubertal children, services should ensure that they can be seen as early as possible by a clinical professional with relevant experience. NHS England should ensure that each regional centre has a follow-through service 17 to 25-year-olds, either by extending the range of the regional children and young people service or through linked services to ensure continuity of care and support to a potentially vulnerable stage in their journey. This will also allow clinical and research follow-up data to be collected. There needs to be a provision for young people considering detransition, recognising that they may not wish to re-engage with the same services whose care they were provided previously under. A full programme of research should be established to look at the characteristics, interventions and outcomes of every young person presenting to the NHS gender services. Puberty blocker trial previously announced by NHS England should be part of a programme research which also helps evaluate the outcomes of psychosocial interventions, masculising and feminising hormones. The option to providing masculising and feminising hormones from the age of 16 is available, but the review recommends extreme caution. There should be clear clinical rationale for providing hormones at this stage rather than waiting on until the individual reaches 18. Every case considered for medical treatment should be discussed at a multidisciplinary team. Implications on private healthcare of any future requests to the NHS for treatment, monitoring and/or developed research, and the dispensing of responsibilities of pharmacists and private prescription needs to be clearly communicated. So, we got through it. It was a lot. I know, it was a lot. But we made it. I'm proud of us. It's a long document. Guys, it's a long document. But we're here. We made it. For us. For us. So, I know I keep harping on, but it is a lot of reading, so if you want to follow me on this little CASS report journey, let me know. Like, follow, subscribe, all that good-ish. And I will see you for another CASS.